We'll give a few minutes to let our listeners come join us with this. So I just want to say good afternoon and welcome back to everyone to the first OC3PR of season 3. I know the challenges of delivering critical care continue even as the COVID pandemic changes into an endemic problem for us all. Our discussion today is, however, on a topic that's been a challenge since ICUs were first created. We will be exploring the topic of long-term ventilation, or as we will learn, perhaps better called prolonged ventilation. For those unfamiliar with this webinar series from Critical Care Services Ontario, Ontario Critical Care Clinical Practice Rounds, OC3PR for short, are presented to help address the challenges that health professionals experience while trying to provide the best possible management to acutely ill patients. Our webinars aim to address the issues through education and the sharing of best practices. The format of OC3PR provides an opportunity for you, the listener, to submit questions, which today will be fielded by Dr. Bernard Lawless and Ms. Crystal Pitfield, both members of the Executive Committee. To submit questions, please type and send them directly to the individual's name Q&A. This webinar, along with previous sessions, are available at both the CCSO website and their YouTube channel. As before, we ask that you do your best to keep yourself muted. Please again fill out the survey at the end of today's webinar, as your feedback is greatly appreciated and will help plan future events. Continue to look for future events at the CCSO website and consider following them on your YouTube and Twitter accounts. There's no question that the use of invasive mechanical ventilation now allows critically ill patients to survive illnesses and injuries that previously would have been uniformly fatal. Although the majority of patients are able to come off ventilators with few difficulties, there is that subgroup of individuals who are quite challenging to safely discontinue their mechanical ventilation. Although we often think of this as an art form, there is considerable science and strategies to safely discontinue mechanical ventilation. Perhaps the use of more standardized approaches, possible use of dedicated centers, are only some of the many questions surrounding the topic.
Yeah, same thing as before, right?
Yeah, the only thing I changed was on the objectives.
If we can ask that someone mute themselves, please.
Oh, like the staff.
Again, the topic of today will be prolonged mechanical ventilation, and we are fortunate with us to have an expert, Dr. Ian Fraser. Dr. Fraser is currently the medical director of the prolonged and long-term ventilation program at Michael Garron Hospital, serving the Toronto East Health Network. He was the founding medical director of the Provincial Prolonged Ventilation Weaning Center of Excellence at Michael Garron Hospital in 2004. He is a member of the Division of Respirology and is the former ICU director at Michael Garron. He has had a long-standing role that supported the evolution of critical care services at his hospital, serving in multiple roles, and is a current member of the Provincial Long-Term Ventilation Strategy Advisory Committee. His research interests are diverse, but include quality improvement in the prolonged ventilation population, models of integrated chronic disease management, virtual care of complex respiratory disease, and the long-term follow-up of COVID-19 survivors. He keeps himself healthy with cycling and long-distance hiking, both events that he'd certainly put me to shame at if we were to do it together. Our objectives today will be to review the topic of prolonged mechanical ventilation. We also hope to identify the process barriers to weaning patients in the ICU, and also to identify common reversible factors that may contribute to causing prolonged ventilation. Finally, Dr. Fraser will help us better understand quality standards for care using the Action 11 framework in regards to prolonged ventilation. Dr. Fraser, Ian, I know you put a lot of time and effort in preparing for today's presentation. Thank you for this, and I look forward to your presentation and the discussion afterwards. I'll pass it over to you now.
Okay, thank you, Dave. And that was, thank you for a great introduction to this topic. I just want to thank everybody for the opportunity to speak on this topic. What I'm presenting is actually the work of many people who I'll acknowledge at the end of this talk. So could I have the first slide? Let's go on to the learning objectives. As Dave alluded to, at the end of this session, I hope you can define the difference between acute, prolonged, and long-term ventilation, identify the major process barriers to weaning from prolonged ventilation, as well as some of the less but common reversible factors, and then understand quality standards through the Action 11 framework and look at options of how to manage these patients both within your unit and with other options outside of your unit related to referral to some of the pilot programs in long stay ICU, which CCSO is funding, the access to the long-term ventilation strategy, including our weaning center, and virtual consultation. Let me start by simply saying that our starting point is the expertise that exists around this chat room and also within the province in acute ICU ventilation as well as ICU liberation protocols. So let's move to the next slide. And you will ask me, what is prolonged ventilation in the ICU? A number of years ago, a consensus definition was developed for acute, prolonged, and long-term ventilation and the transitions from acute to prolonged. And it's actually quite intuitive and makes sense. And I think it's been robust over the many years since it was first developed. First of all, the patient must be physiologically stable. There must be at least 2 or 3 unsuccessful weaning attempts, and the patient wishes to continue therapy. And the number of factors that contribute to that are obviously related to premorbid factors, diagnosis and prognosis, the quality of life, the motivation of the patient and the family, and of course, an establishment of a clear ventilator weaning plan. And you asked me, when does this change in state from acute to prolonged ventilation occur? Well, if you look at the work that's been published across a number of healthcare systems, critical care systems, you look at the work by Washna here from Australia, New Zealand, who shows that around day 12 to 14, there is a change in the major factor affecting mortality. And it changes from the acute physiologic presentation, in other words, the acute presentation, to the factors related to the premorbid chronicities. And this, as we found out by talking to most clinicians, is where you start thinking about prolonged ventilation. Next slide. Why is it important? Well, across Canada, it's about 1 in 10 ventilated ICU beds, 50% mortality, 50% readmission rate for survivors. In our hands, in our weaning center, about 90% of those patients are actually diverted away from what is called long-term ventilation. And I use that term long-term because it's the preferred term by our patients and families. They don't like the term chronic. And at that point, the patient is on the ventilator for an indefinite period. There's been an option of withdrawal of therapy given. There's a plan in place. The patient is physiologically stable. So these are patients that, in my opinion, should never be in an ICU. They should be cared for outside of an ICU and even in the community. In May of this year, CCSO did a point in time survey looking at markers that would identify people with prolonged ventilation. In other words, 10 or more days of prolonged ventilation. They found a significant number in the healthcare system, almost over 250, with a median ventilation time of about 41 days. Now, the challenge is, as you know, as clinicians, many of these patients were unstable, but that's a significant number of beds. And for each patient who's in a prolonged ventilation bed, that's the equivalent of 70 of the usual average short stay ICU admissions a year. So they also, in this population, have multiple transitions of care. Their caregivers suffer depression, anxiety. There's a low probability of return to independent living. And some estimates up to 30% of our ICU costs. So next slide. We base our approach in weaning, both acute or prolonged, on this ventilator dependence model. And it's a paradigm all of us intuitively use at the bedside. Patient becomes dependent on a ventilator when their respiratory capacity is exceeded by the respiratory load. And you can see the factors related to lung disease. I would add airways disease there, cardiovascular dysfunction, and chest wall disease. And the capacity obviously related to muscle weakness, related to critical illness, diminished respiratory drive. And I'd like to point out specifically impaired neuromuscular function, because this is a unique opportunity for weaning if in fact you have normal pulmonary mechanics. This is a subpopulation which responds to cough augmentation, lung volume augmentation, cough assist, and non-invasive ventilation. And you can get specific advice if you don't have a lot of experience in this area by contacting the long-term ventilation strategy. And we have some superb experts internationally known in the province for this. Next slide. So I'm often asked, what are some easy things that might have been missed in when it comes to weaning? And we did a retrospective survey a couple of years ago, looked at 100 consecutive admits to our weaning center. And what we found is actually very few things that might have been missed when we did the usual admission diagnostic workup. I think this speaks to the excellence of care in the ICUs across the province. And as you can see there, there's not a lot of them, like untreated hypothyroidism, upper airway obstruction, unrecognized asthma or COPD, obesity or hypoventilation syndrome. And interesting, some undiagnosed neuromuscular disease when the patients actually wake up a bit, sepsis. And what I found fascinating was one thing that we uncovered was a family who didn't understand the natural history of the underlying disease. They didn't appreciate the fact that the disease was not reversible completely. And when we actually shared that with them, they understood the natural history of the disease, we were able to provide a different weaning path. But the next slide actually talks to the barriers, which are predominantly process and organizational, which are the ones that are the challenges for all of us in the field. In an acute ICU, there are competing priorities for acute ICU care. I remember Margaret Herridge talking about the fact that it's hard to approach these patients who've been in the unit for weeks when in fact you have a patient with no blood pressure and are profoundly hypoxemic. Those are the patients you have to take care of. Nowadays, all of us are suffering from staffing shortages, but the optimal care of this population requires developing and implementing an individualized care plan, which goes not only beyond weaning, but communication, mobilization, nutrition, et cetera, and ensuring there's continuity day to day, week to week, weekend to weekend. And in my experience, as these patients are in the unit for more and more periods of time, there's a higher risk of patient, family, and ICU team discordance, which is a barrier to cooperative planning for weaning. And we're dealing with something, as Dave pointed out, about the subpopulation that have an intrinsically prolonged recovery from critical illness. Next slide. So how do you approach this? What's the best way to treat these patients? There's an interesting ethnography study that was published a number of years ago, looking at high-performing long-term acute care units in the States. Those are essentially non-ICUs that provide acute care with ventilation after day 21 in the ICU. And they're usually not in the ICU organization, they're usually outside. And they identified what were the thematic characteristics of very high performing units. And it was interesting when they looked at it, they looked at leadership as a key determinant and attribute, and a sense of a clear priority for quality improvement and enabling their staff, physician staffing, very much like an ICU, 24/7 dedicated staffing. Nursing staffing, you know what, when I read this paper again a few days ago, I was sort of dreaming of the fact that they were talking about proactive planning, redundancy, adequate staffing. They even mentioned a nursing residency for having nurses working in this area, being trained and coached and mentored for a period of time before they actually worked in the unit. Protocols and pathways, which we're all familiar with, but ones that are enabling and allow autonomous practice of RTs and other staff with the ability to customize it to the individual, but also to be able to break the rules a little bit. Continuity of RT, PT, and OT staffing, same individual taking care of the patient day to day over a long period. A full ancillary interprofessional team, including specific components of emotional support. And what was interesting is about the team meetings. Weekly team meetings, interprofessional, designed to problem solve, not just to report, that had physicians actively involved. And were also associated with informal huddles. Now, as I was reading this, I'm saying, well, this sounds like a really high-performing ICU by any other name. But these days, it's really hard to do, especially if we look back at the last couple of years of the pandemic. And finally, the plant. The physical plant talked about large spaces to meet near where you're giving care, and also large rooms for families. Families can be with the patients. So that was interesting. So this may be good evidence. You go to the next slide. For developing a model of care which looked at these organizational and team factors that engaged families, produced effective practices, and had good patient and family outcomes. And they talked about this optimal balance of aggressiveness and responsiveness, which is an interesting comment. But for those of us who work in this prolonged ventilation weaning field, it makes sense. We often push our patients more than perhaps is conventional. Next slide. So how do you set the priorities for what this great team that we are going to put together look at? And we're fortunate, recent work by Rose and Isteboulian and et al. Have developed a Canadian-specific, cross-Canada, co-designed, consensus-based list of high-priority, actionable quality processes for this population. They looked at They had patients and families as well as a whole variety of care providers, approaching almost 200. And they identified 11 major actionable processes. And the checklist is actually much more complex. It has multiple other sub points, but it involves, interestingly, involving the patient and family in goal setting, decision making, an emphasis on communication, including ability to call for help, physical comfort, including things such as simple as thirst and making sure they don't get complications, a promotion of self-care and normalcy, ventilator weaning, as we would expect, physical therapy. I'll just point everybody to the CCSO's toolkit on mobility, assessment of swallowing and establishment of safe return to normal drinking and eating. You notice the communication and swallowing are high priorities here. De-escalation, which we all tried to do, but it's an intentional thing when it comes to an actionable process. Assess and treat psychological issues such as anxiety and depression, minimize delirium, and appropriate referrals. Now, this is quite a mouthful. In fact, we're in the process of trying to figure out how to implement this in our unit with an evaluation trial. And the appropriate referrals referred to a wide interprofessional team, not just other physicians and specialists. So the next slide just gives you an example of how it would be broken down when it comes to optimizing ventilator weaning. And, you know, the idea of something as simple as visually tracking ventilator weaning progress using a structured tool, which we talked about, involving the family. And then an emphasis on the tracheostomy. And let me just, a little sidebar here. One of the things that we found quite useful, and it's evidence-based, and many of you already have, but I was encouraging everybody to think about a dedicated interprofessional physician-led tracheostomy team. In our institution, it has basically eliminated tracheostomy complications and readmissions to our unit. Strategies to manage excess secretions and cough. Cough assist, as we know, is underutilized. And of course, as we alluded to, endocrine function. Next slide. So now that you have the process, you have the priorities, how do you implement this in your unit? If process is the issue, you should use a process improvement model. And the simplest one around is the PDSA cycle. And I've adapted that here into 4 major points. Set daily goals, not weekly goals, daily goals. And this, you know, use the Action 11 priorities to help you with that. But weaning goals should be set every day. Ensure continuity. That's a tough thing to do, simply because staff change frequently. There's a number of models that are used around this province, including an intensivist continuity model with a single intensivist that has a overall view and relationship with the family. I actually think a more robust, easier one to use is to have a nurse specialist, a nurse practitioner, an RT, coordinating care week to week, day to day. The idea of weekly dedicated interprofessional rounds, and I would strongly suggest and urge people to have proactively scheduled regular patient and family meetings. It's easier said than done, but it will help continuity. Trend, of course, graph weaning progress. If you can, and you can use the tool of a dedicated health record notes with standard documentation. And finally, individualized care. It works for these patients who don't really follow the rules sometimes. They don't quite fit the pattern and they're challenging. Feel free to consult experts. Through our Weaning Center, there's virtual consultation available anywhere in the province. So just email us and we can set it up. And one thing I believe is quite important, try to find a non-acute ICU environment. If you can do that by finding a part of your unit or a segment of your unit that is not an acute ICU, or even transferred to a specialized unit, that would be ideal. And the final slide before we get to the case presentation is, I think I would describe this as a note of incredible optimism, because there is now many resources across the province, both in the acute, rehab, long-term, and community, to provide care and advice for prolonged and long-term ventilation patients. And this is just a sampling. It's not extensive. When I actually tried to look across the whole province, I wouldn't be able to fit it on a full slide, but I wanted to give the audience a sense of where we are right now in the province when it comes to potential resources and what is developing. And this is different than what it was even a few years ago. In many ways, the pandemic has been a catalyst to help this. And so the gray boxes are simply programs that are present in some of the institutions which are vertically displayed. And as you can see, in the acute sector, there's non-acute ICUs, such as in London with their critical illness recovery programs, some of the pilot programs at Mackenzie and Michael Garron and long stay ICU. There's our Weaning program, which is an acute sector, but outside the ICU. And then there's also rehabilitation recovery programs with many who do weaning. And finally, there are resources in the community for our long stay patients. Now, Dave, before we go on to the case study, I just want to make a plug for a webinar next Thursday morning discussing the provincial long-term ventilation strategy. And if you or part of your team can make that, I think it would be incredibly useful to have a deeper understanding of the resources for that population. So I'm going to stop my formal presentation. Let's go on to the case study. And my question at the end of this initial day 3 presentation is, do you recognize the patient? So this is a 65-year-old, 30-pack year, smoking, obese, treated hypothyroid, diabetic, hypotensive, lives alone, widow, who has depression, atrial fibrillation. She has MRC class 4 COPD, mild CKD, and a past history of surgery for benign bowel obstruction. And she has a frailty score of 6. She needs a little help at home. English and Francais is not her first language. She presents with acute hypercarbic COPD exacerbation secondary to diffuse influenza pneumonia, comes to the ICU for 24 hours of NIV, improves, and then because of the situation we're in, with the emerges, busting at the seams, needing a bed for 3 patients who really should be in the ICU, we discharge the patient to the ward on the evening of the weekend. And the next day, next slide, she comes back to the ICU, massive aspiration. It was a difficult intubation. 3 operators, finally the intensivist arrives and intubates the patient on the first attempt, but with difficulty. Resuscitated and invasively ventilated, full resuscitation, pressors, paralysis, IV sedation, IV antibiotics. And you can see the labs which show permissive hyperventilation, platelets are down, creatinine's up, ACE inhibitor stopped, normal range of lights. And so my question to the audience is, have you seen this patient? And I can't see everybody, but I think I'm seeing some nodding heads. So let's go on to slide 2. Day 14. A tracheostomy and PEG tube has been inserted. Failed weaning attempts. Longest trach trial is 15 minutes. Treated for pneumonia on day 10. Vasopressors are on and off for a soft blood pressure. They've only been able to schedule one family meeting, and at the family meeting, the 4 children could not decide on a single family contact. There's worsening AKI. You're thinking, maybe might need renal replacement. Of course, GI bleed. You stop the apixaban. Next day, the patient is more delirious. The CT shows a small embolic CVA. And the best we can do with mobility is lift the patient to a chair, and that's it, beside the bed. So the question I'm going to stop now and open the forum for questions. Is this patient in the prolonged ventilation population?
I think so, Ian.
I think it's a bit of a rhetorical question, but it's interesting. It's so easy when you do things in retrospect and put everything down on paper. It's easy to do. But let me tell you a couple of the clues that I would sort of use to identify that. The dates don't work. We've had a number of definitions over the years related to dates, but the fact there's a tracheostomy and PEG in place means the team's pretty certain this is going to be in for the long term in the ICU. The other thing, of course, is that weaning's not particularly going well, and there's been another infectious complication. So this would be a patient that I would be saying, maybe we should prepare for an approach which is different than acute ventilation. And that might be a time to do a couple of things. It might be to think about maybe giving us a call. If you're in the catchment area of the pilot programs for the long stay units, ICU pilots, might be a patient for them. But the other thing that really raises a red flag for me is the family engagement. So if there's no other comments, Dave and Bernard, I can't see any of them. So I'm going to take your cue for moving on to the next slide, if that would be all right. Okay. Day 21, I'm sure many of you will recognize this patient. Weaning progress, 1 hour at most, twice a day. Weaning, thick white secretions. There's not a lot of evidence of infection. Still, FiO2 is high. And I'm going to just look into the unit right now and do a process check. And the process check is that the weaning plan changes from week to week when there's a change of staff or team. family meeting is being scheduled, so the family's not quite as engaged as you would ideal. Communication is limited because all you have is a little lip reading, but the family translates and some gestures. So it's hard to engage with the patient. Good news is the PEG tube feedings are working. Sedation's reduced. Still needing the vasopressors occasionally. Creatinine's high as heck, and there's generalized edema. And if you look at the chest X-ray, you don't need to see it in detail, but you can see there's large effusions both sides. So this is a patient that I would say is not going to wean quickly. And mobility is not a good state because two-person just to get to sit up, and the patient is delirious with day-night sleep reversal. So I would just ask the audience right now, any thoughts about management in addition to what I have posted up there?
Well, and since we asked them to be muted, I'm not sure you'll get as many answers as you hope, but obviously I have a few ideas, but okay. I can actually share what happened to this patient. The ICU group put in a right-sided pleural catheter and drained 2 liters of fluid. The AKI started getting better, creatinine going down, started a little bit of diuresis, and things got a little better, not a lot, but a little, okay? This is a time when I think the trajectory is clear. And again, you can think about, asking for advice as you would with any other specialist. You might think about a long-stay ICU unit if it's in your area, because this is the type of patient that they're designed to take care of. At least that's what they are hoping to. So let's go on to the next. If you go back one, and we're almost finished. Could we go back one more? Thank you. So I just saw something in the chat here. Yeah, about a single assigned family MRP. I think that's a really good idea. That's part of the intensivist continuity model. And I think that's a really excellent idea. So by day 28, we're up to 4 hours, but we tried all sorts of modes. Things really haven't worked. The cough assist is working to help clear the secretions. Line sepsis, we always look for it, but so the PICC line's out. We've got a family meeting, but the family meeting is, well, we've got a goal by the patient to return home, but not a lot of nuances about values and quality of life. Unfortunately, it was a fall just the day before they were going to have the following family meeting. And the patient rep is having multiple complaints. So the good news is there is delirium management plan in place, which is seemingly working. One of the things they found out is that the patient is addicted to soaps. So they gave her glasses, and they actually had a television for her favorite soaps, and she actually brightened up. And she liked traditional music, and she culturally always had a nap in the afternoon. So they changed the pattern for sleeping and the routine in the unit, and things improved. They've gotten rid of the restraints, and she's been moved to a quieter single room. So the delirium is better.
And I have two more slides, and then I think we can open things for discussion and questions. This is a weaning chart from this patient. It's a daily weaning chart from our electronic health record. So let me orient you. Vertical axis is hours per day. Horizontal axis is days. The green points are targets set by the team on a daily basis. The reality is the blue. And there was a charting error at the beginning because one of the regular RTs was off because of a family illness. There was an episode of sepsis with that really put quite a setback, but then things improved. And what I'd like to point out is towards the end of the weaning chart, you'll see that there was an episode of mucus plugging, 2 episodes of fatigue. There's venous gases there. Her usual venous gas was around 50 for PCO2. And so she's plateauing at about 15 to 16 hours, which is not an uncommon situation. And this, to me, is a perfect invitation for non-invasive ventilation at night as a bridging strategy to allow this patient to leave invasive ventilatory support. So next slide. And that is, in fact, what actually happened. In addition, what happened around this time was speech-language pathology was consulted. In retrospect, they probably should have been consulted much earlier. And with the help of RT, she was using a speaking valve, which as soon as she could speak, it's as if the floodgates opened and she started to wean. Foley's removed, 2-person assist, and the long story is this patient eventually weaned with nocturnal non-invasive ventilation. So we have another comment in the by Dr. Mehta, which I agree with completely, quoting Osler, and I'm going to ask everybody to have a chat at that if they can. So next slide. In summary, I hope that you can, after this talk, recognize this prolonged ventilation population and specific definition as it differs from long-term and acute, identify common process barriers and individual reversible factors, understand a framework of quality improvement actions for the Action 11, and look at options for management for this population, including individual PDSA approach with setting goals, ensuring continuity, trending progress and individualizing care, be aware of the option of virtual consultation, where available, the option of the pilot long stay ICU units, and the ability to contact the long stay ventilation strategy for patients who in fact move on to long-term ventilation or bar weaning potential. So Dave, I'm going to stop there and I'm happy to answer any questions. And I thank everybody for their comments.
No, thank you, Ian. There's a lot there. I have a lot of questions. I'll go to Bernard in a minute, and then Crystal. The case that you illustrated and the changing physician at the very least on at least weekly, and if you have residents, sometimes even more frequent for subtle differences. What is your strategy to separate them out? Because ideally, we would all have separate weaning units. I recognize the infrastructure of a hospital, to have the proper ventilation and removal of gases limits to someplace. What would your recommendation be? Would it be to have a sub area in the ICU? or somehow advocate so that you could have a separate weaning unit outside of the traditional environment in that regards?
I think the literature, which is, there's no RCTs on this, but the consensus is a separate geographic unit outside of the acute ICU. Now, you know what it's like. Every hospital has a different architecture. Sometimes your ICUs actually have separate areas. But the idea, even though it's on the same ICU floor and they may even have the same intensivist, but to have it physically separated so you can get rid of the noise, the usual process factor, the incredible intensity that is part of an acute ICU, I think is essential for this population.
No, I mean, that's the perfect world. I wish we could all do it. The final component, and then I'll go to Bernard, is who should be caring for these individuals? Would you say ICU, or is this a respirology or a rehab? I think that's one of the issues with prolonged ventilation, long-term ventilation, whatever preferred term, is it almost doesn't have a group that is, you know, primarily involved. And I often say we don't have patient groups, you know, waving the banner for it as much, but I don't know who owns it, and who do you think?
You know what, I think, let me say that I think the most important physician group to take care of these patients are the ones who have a specific interest and expertise in it, period. And I will say, when it comes to prolonged ventilation weaning, as opposed to ICU recovery and long-term ventilation, whether it be residential in an institution or in the community, I think that group is probably best cared for by people who are comfortable with chronic respiratory disease. So I think that's leaning towards more respirology. However, when it comes to acute, the acute sector, when it comes to the classic weaning centers, which I think you're talking about, I think it can be run by either group. It's a matter of interest and shared expertise. I practice primarily in respirology there right now, although my background originally was in intensive care. And many of the people that are cross-trained in respirology and ICU are almost ideal for this. But, you know, Dave, if I might be so bold as to talk about what the ideal, you know, prolonged ventilation weaning center might be, I think it has to be near where the patient lives and the families. I think you're right, it has to be separate from the ICU. It has to be part of a larger organization for sustainability of staffing, both physicians and not. And it should be integrated into a system where the graduates of the weaning program from prolonged ventilation weaning, in fact, can go to rehab either in the community or institutionally and be followed on a long-term basis for chronic disease management, so they don't get readmitted and we see them again in the ICU and we repeat the cycle. So I've been a little long-winded, but I hope I answered your question.
No, a lot of good thoughts. I'll go to Dr. Lawless and then Crystal, and I'll pass it over there for now.
Dr. Fraser, thanks very much for your presentation. I think it was a good encapsulation of an issue that's very complex and has a lot of facets to it, but I think it's a very good summary of highlights of things that we need to keep in mind looking after these patients. One of the questions that came in is, I would like to know an answer, is there evidence to support that any one mode or weaning strategy is more successful than others? For example, using a proportional assist mode compared to using CPAP with pressure support.
The short answer is no.
Yeah.
And that's part of the challenge. There's one RCT, but it used a mode of assist control versus trach mask, which we don't use very much anymore. So I'm a firm believer that if you have expertise in your organization or unit, and you have a robust protocol, and you enable the RT and staff to autonomously execute it and have the team individualized if necessary, that's the success factor.
Yeah. And I suspect it's a lot predicated on many factors in terms of the underlying condition of the patient, how long they've been in the ICU, what their deconditioning status is like, and things like that. So you really have to kind of think about many of those things, I think, to try to tailor then what the weaning strategy would be, or the ventilator modes would be before you can.
Yeah, I would agree. The importance of individualization, and maybe I'll take issue with what Dave alluded to. I think there is a bit of an art here, even though there's evidence and science behind it.
Yeah, I noticed that Dr. Cargill had his hand up, and Marcus said, if you wanted to interject here, you can unmute yourself.
Am I able to? Can you hear me?
Yep.
Oh, okay, great, thanks. I just wanted to follow through with Dr. Neilipovitz. You asked about the continuity of care, and just so you know, I'm a respirologist, former intensivist. I work with Ian at the Weaning Center here at Michael Garron Hospital, for those of you who don't know me. We have a wonderful nurse practitioner, Laura Istanbulian, who helps greatly with our continuity of care that we provide to our patients. And I think that's a little bit different than what we offer in our own ICU and maybe what some others can offer. That point of contact is vital, I think, for the patients' families to have someone they can access easily with questions, all the stresses that come with having a relative in critical care. And with the in weaning, and with the very long timeframes that surround many of these weaning cases. And in Ian's case presentation, as is typical, the patient has numerous complications and really needs a lot of patience to let the body heal, let the physiology recover, let the chest infiltrates recover, and hopefully without more complications as time goes. And during that time, families need the help of a point of contact. And I think our nurse practitioner, Laura, does a wonderful job for that for them. So I think that's quite helpful.
Yeah, there's a number. London has a long history in their unit of a nurse specialist who does a similar role. So I think pragmatically that might be a good, widely generalizable solution, rather than trying to add additional responsibilities to physicians who are already stretched in many organizations.
No, good thoughts. I mean, to way beyond the scope of a webinar is how do you fund said individual, and how do you set up that so there's an economy of scale? Certainly, would be quite interested offline to discuss it, because I think we all recognize the need for this, at least in regions, if not sub-regions, but it's easier said than done to set that up. Bernard, did you have another question before we go to Crystal? You're on mute. As Dr. Lawless struggles with his mute button, I'll go to Crystal. Crystal?
Thank you. Thank you very much, Dr. Fraser. Lots of compliments and questions coming in on the chat that you probably can't see. One of the questions, I know you talked about access to rehab and the importance of the services. A question came through, is there movement provincially to concentrate the prolonged ventilation weaning patients into centers of excellence, similar to burn, spinal cord injuries, or is it more of a distributive approach?
Okay. There's a number of initiatives that are underway, and Bruno can probably speak to them with great greater understanding than myself. But prolonged ventilation weaning does not have a large number of dedicated centers. I think realistically, what we've learned over the years is a distributed model probably works better rather than a highly centralized one, and that is simply because the important component of success in prolonged ventilation weaning is the family. And if they have to travel extraordinary distances, it's very, very hard. I think the idea of regional weaning centers where numbers warrant makes a lot of sense, but you would have to integrate it with probably a virtual care component to allow access across the province. But those are my thoughts.
I can add a little bit to that probably, in that there are centers across the province outside of those that we traditionally think of as these centers of excellence, where there is weaning that occurs and patients get transferred to these areas or to these units. And if they require prolonged or long-term mechanical ventilation, then there's programs to help assist get them to their next sort of spot on the journey of their care continuum, whether it's home or whether it's in another facility or things like that, or reintegrated into community. And I think the idea of these centers of excellence really is around developing the knowledge and the best practices, and then being able to disseminate those to other centers that are capable of doing some of the weaning practices and keeping patients closer to home. So there's quite a bit of work currently going on to try to establish a more networked sort of hub and spoke model where there are centers of excellence and where the knowledge is being developed on how to best manage patients who require prolonged ventilation. Ottawa does a tremendous amount of work. London has long-standing, history of doing a dedicated piece of work with this patient population, and as well as, of course, the centers around the GTA, of having them develop the practices and the protocols and be a resource to other centers, like smaller centers that are weaning patients, as Ian mentioned, to be able to reach out, have a consultation, potentially virtual consultation. And so those are things that we'll hear about more in the coming near future.
Thanks, Bernard. I'm cognizant of our time. Perhaps, one last plug for your LTV strategy webinar. I trust people can copy the link for that. I suspect I had some questions about cough assist devices and your trach team and things like that. Perhaps that's involved in your webinar, or certainly people can follow up with that.
That's right. You know what? They can actually. I'm glad Dr. Cargill's on the line here, because he's been instrumental in developing protocols, and that team, he's led it. So they can reach out directly to me, and I will connect them with Dr. Cargill about that.
Excellent. Crystal, any final questions before I go to Bernard for closing comments there?
One question from one of the ICU physicians was, if you were going to start improving weaning strategies or starting great weaning strategies, is there one aspect that you would focus on first of all your great ideas?
You know what? I think it would be the Action 11 framework. Okay. Because it's not just weaning that is part of the care of these patients. What is success is taking care of the whole patient. And that sort of approach allows you to identify priorities. And that will give your team a guidance to do that. And hopefully we will, within the next 6 to 9 months, have a optimal implementation strategy. So that happy for that person to reach out to me about that.
That's a fantastic way to finish, Ian. I just want to say thank you on behalf of OC3PR for a very informative and comprehensive, at least introduction to an approach to prolonged ventilation. I do think we'll be coming back to this topic, as it certainly isn't going away, and if anything, is becoming a more prevalent challenge that we all experience. I would just remind our watchers to do their best to fill out the survey. Look for upcoming discussions where we're hoping to talk about early warning systems. And again, Ian, thank you so much for taking the time and effort to do this. And Bernard, I'll go to you for some final thoughts.
Yeah, I echo the similar comments as Jay's. And Ian, thank you so much for being able to be with us today to do this presentation.
My pleasure.
As long as I've been around, which is sometimes feeling old, you've been such a presence in this area of medicine in terms of prolonged mechanical ventilation, as have others in some of the other centers like Dr. Lisa and those in Ottawa. But it's, as you say, it requires a patience that we don't always necessarily have in our day-to-day type A world. And it's reassuring to hear those elements, I think, of when, of what it takes to be able to try to manage some of these patients and along with their families, but also the whole spectrum of the care in terms of the wraparound of the patient and the family and the psychiatry and sociology of it all, that it really is a deep, broad field that requires a lot of focus. It's not just changing the ventilator settings from day to day and hoping that patients wean and get extubated. And so thank you for there were so many facets of the case study that you presented that just ring, resoundingly familiar of areas where there's junctures along that way where we can have either a different conversation or a different way of looking at it, and trying to be consistent in how we do that from week to week. So anyway, I really appreciate your presentation. Thank you for joining us for this today. And thank you for everybody else who participated and were able to join. This will be, as noted, posted on our YouTube channel via our website. And enjoy the rest of your afternoon.